Dear ESTS members and webinar attendees, my name is Lieve de Diepere, your moderator for today. This webinar is the last one of the third season of the ESTS educational webinars, and the subject today is stage 1A lung cancer, with the question on whether we should go for radiation therapy or for surgery in some specific cases. Therefore, we invited two experts in the field to comment on our cases for today. The first expert is Dr. Hale Caglar. She's a radiation oncologist and radiation oncology director at Anadolu Medical Center in Istanbul, in Turkey. And she's also professor in radiation oncology, and one of her subspecialties is thoracic oncology. So welcome, Professor Caglar.
Thank you very much.
Is Dr. David Waller. He is the longest-serving pure thoracic consultant surgeon in England, with an amazing track record on different topics such as mesothelioma surgery and emphysema surgery. And he is consultant thoracic surgeon at St. Bartholomew's Hospital in London. He has been member of many different guideline committees, and he's currently counselor in our ESTS board of directors. And one of his favorite research topics is focused on the group of patients with poor lung function, who could conventionally be denied surgery. So this is very important also today. So also welcome to you.
Thank you. Good evening.
We will ask a lot of interaction and interactivity of the audience, so be ready to answer the poll questions, and please ask as many questions to the expert as you want. Let me start with the first poll for the audience. In order to see what the professional distribution is of our audience for today. I'll just launch this poll for you. So in your right sidebar, you can see the polls. And there you can see what is your professional specialization. You can answer on this. So you don't have to answer in the chat, but go to polls, and there you can answer. You can do this now, then we have an idea for the audience on what kind of subspecialization you have, if you are a surgeon, radiation oncologist, medical oncologist, or maybe something else. I have the impression that there's a problem because I don't see any votes yet. Can the speakers see their right sidebar poll? Yes, they can. So I hope for the audience it's the same. And there you can vote. Do you see any votes coming in? I don't see any votes.
Yes, I can.
Okay, then it's good. Okay, now I can also see that. So that was a hiccup in my program here. We have 95% of thoracic surgeons for the moment, which is logic in the ESTS, of course. Let me start with the first case then. I'm going to share my screen. So this is the first case. A 65 years old female. She's an ex-smoker, 42 pack years. Stopped in September 2012. COPD gold stage 2 with some buffers she has. And since 2008, follow-up of a small lesion in the right upper lobe. In 2010 and 2011, she had an infectious COPD exacerbation. And in 2012, a VATS wedge resection of the right upper lobe. That was an adenocarcinoma, followed by a completion lobectomy with lymph node dissection, PT1A in 0. Postoperative, she had a prolonged air leak, and she was sent home with a Heimlich valve, but no further problems. In November 2012, she had a wedge resection of the left upper lobe this time, and that was COP cup with granuloma formation. 2013, again, multiple COP reactions with regression under corticosteroids and antibiotics. And then she also had a BAL in 2013 with Mycobacterium poriferae, which was probably contamination and Aspergillus. In chest CT in 2013, she had emphysema and small ground glass nodule in the left upper lobe. So the chest CT of November last year was showing this. I'll show you again. Clinical examination, she had a WHO performance status 0, BMI of 24, and lungs have normal auscultation. A new chest CT in March showed this. As you can see, multiple small nodules, one bigger one. And on the PET CT, you see the lesion in the left lower lobe with an SUV max of 9.2, and this is actually the only lesion you can see on the PET CT. No lymph nodes described. Bronchoscopy, EBUS mini probe detection, lesion in the apical segment of the left lower lobe, as we had seen before, and this shows adenocarcinoma. What treatment would you offer? And this is a question, of course, to the audience. Again, in the polls, you can answer there. Stereotactic radiotherapy, surgery being lobectomy, surgery being segmentectomy, or I don't know yet, I need more information.
Do we know about the size of the tumor?
This was, let's see if I can go back here. Seems not. My computer seems to be blocked. This is interesting. But it is about 1 centimeter. I really have a problem. My slides are blocked. Okay, I'll try to show you again. No, my screen is still on my PowerPoint. Never had this before. In the meanwhile, let's have a look at the answers. Most of the surgeons are saying, or most of the audience, but these are surgeons, are saying segmentectomy, closely followed by I don't know yet, I need more information. And that's actually what I want to try to show you. Okay, my computer is really blocked. I'll try to show you in another way. I'm very sorry for this technical issue. It was already trying to help me, but I'm sorry. think this is be okay. And then okay, I hope the PowerPoint is staying where it should be. So we have an additional lung function, FEV1 of 68%, DLCO 75%, and then for lobectomy and segmentectomy, being segment 6, we calculated the postoperative predicted FEV1 and DLCO. Cardiology advice showed structural normal heart and no signs of ischemia after a cycle test. So what would be the treatment that you offer right now? You can again vote in the poll system. And then it's going very fast, as I can see. And 2/3 of the audience are saying segmentectomy. 1/4 is saying lobectomy, and actually 10% stereotactic radiotherapy. Okay, this is very interesting. I will just wait with what we did in this case, and ask the experts what their opinion on this case is. Mr. Caglar.
Well, okay, so this is a 64-year-old lady who had multiple interventions in her lung for a prior cancer and has comorbid illnesses. Obviously, this is a peripheral new lesion in stage 1A. So looking at this pulmonary functions, well, I think both surgical options, segmentectomy option, and the stereotactic body radiotherapy option could be discussed with the patient. What we do in our hospital, we always discuss these issues in a multidisciplinary team. And it is a multidisciplinary team approach, putting the patient in the center. Obviously, we give feedback about the projections of the treatments, both the surgical options and non-surgical options. And we discuss this with the patient, and we hear their options about it as well. But looking at this pulmonary function test, I cannot deny that segmentectomy could be an option for this patient as well, but I would like to discuss stereotactic body radiotherapy option with her as well before proceeding with any intervention. That's our issue.
Okay, Dr. Waller.
Okay, I'll just share a few slides on this case.
For sure. I hope it goes more smoothly than mine.
So it's a fairly difficult decision, but not as difficult as some that we're
asking. I cannot see your slides yet. So if you share first, and then your entire screen, and we go to the PowerPoint.
Okay, can you see those?
That's good. We still don't have the presenter modes, but yeah, it's coming up now. Perfect. Thank you.
Okay, so I note the previous right upper lobectomy, which may influence the surgical decision. I note the history of COPD. It's relative COPD, not as severe as some patients we operate on. Importantly, I noticed that the patient has had previous surgery on the left, albeit left video-assisted surgery, but will certainly create some surgical problems because of adhesions, and has had infective lung disease as well. There undoubtedly will be adhesions on this side. I note that the lesion is resectable by an apicoloa segmentectomy. I would attempt robotic surgery, but would consent the patient for at least a 10% possibility of thoracotomy. Because
we lost you.
I've done nothing.
No, but we lost Dr. Waller. I don't know what happened. His slides are still on. And this was okay. I hope he's coming back in a minute. It was just becoming to be very interesting. Yeah, there he is. Now you are back on online again, but we lost your slides now. I don't know what happened. We seem to have some technical issues today.
Let me just share the screen again.
Okay.
It's still working on it.
So you mentioned the previous surgeries already, and you were planning to go for robotic resection.
Let's say we go for robotic segmentectomy, consenting the patient for a 10% chance of thoracotomy due to previous adhesions, previous surgery and adhesions from previous surgery and possible infected lung disease.
The sound is worse than it was. We also have a feedback. I don't know if the headphones are connected well or.
Can you hear me now? How is that?
We can hear you, but it's still with some feedback.
Okay, so my conclusion would be robotic segmentectomy.
Okay. Okay. So what we actually did was we went for stereotactic radiotherapy with a total doses of 54 grays in 4 fractions. And this was indeed because of the previous surgeries the patient had. We also discussed it with the patient, and it's indeed it is not impossible to do a segmentectomy, but the patient already had enough surgeries, she thought, and we chose for the stereotactic radiotherapy. Any questions from the audience? If you go
During the meantime, I would like to comment. I think this is the most important thing, especially when you're dealing with very difficult cases like this. We need to meet in a multidisciplinary approach, and everybody has to be in the room with the patient. And we need to include the possible potential risks and benefits of each strategy. And we need to include the patient in the decision-making process. I guess this has to be the most important thing we need to take back home after this case.
Mm-hmm. I fully agree on that. The audience is not having any questions yet. So maybe we go to a second case and hope, and there is a first question. How was the follow-up, and what would you offer the patient if the lesion still grows? Regarding the follow-up, the patient just had finished the radiotherapy, so we don't have any follow-up yet, but I'll ask the question to the experts. How would we go for the follow-up?
Okay, so this is one of the most strategic and challenging things about the response evaluation of stereotactic body radiotherapy to a lung cancer. We really do not know the routine way of follow-up, and we do not know how to define the local recurrence and when to do the salvage treatments, because there are different options for that. But fortunately, very recently, guidelines have been started to be published about that. So the best way to do the surveillance after a lung SBRT is to do a CT scan every 3 months for the surveillance. And the different type of radiological outcomes have been defined because, you know, there is the inflammatory response coming with the radiotherapy as well. And if the radiologist is not an expert in this area, then they may define the response as a false positive after the radiotherapy. But in order to define a local recurrence, obviously the best way is, especially if the patient can be salvageable in a medical condition, if his or her medical condition can be salvaged with surgery, then obviously there is a need for a tissue biopsy to do a salvage resection after the radiosurgery. So the guidelines recommend routine CT, thorax CT surveillance every 3 months. Sometimes we include a PET scan in this surveillance as well.
Okay. Dr. Waller, any comments?
Well, I think this highlights the problem of stereotactic radiotherapy. It means the patient is left in doubt under long-term follow-up, facing further invasive investigations. And I think this needs to be made clear to the patient before they embark on radiotherapy. After surgery, they would have maybe CT scans twice in the first year, and then maybe annual CT scans, but would very unlikely to require further invasive procedures. And I think that would be a better longer-term outcome for this patient. So I think when they consent for radiotherapy, they should be explained what this entails in terms of a more involved follow-up, several more returns to the hospital, and possibly further invasive biopsies, and a degree of uncertainty for many years.
Okay, I think this discussion we can go on further after the cases. Also, some questions that come up between and the outcomes between or the differences between SABRE compared to segmentectomy. I think we can have this in the general comments. Let's move to the second case, and then we can answer questions, as many as you want. No problem. Dr. Waller, the sound is still not very good. I don't know what we can try to improve, but I'll go to the second case in the meanwhile. So this is the second case. Provided by Dr. Novoa from Salamanca, Spain. So this is not from my hospital. 83 years old male, on consultation self-limited hemoptysis, and the patient is an ex-smoker since 2002, 60 pack years. Active daily life with walking 6 to 8 kilometers per day. Patient has atrial fibrillation, arterial hypertension, coronary artery disease, CABG procedure 3 times 2007, and current echocardiogram showing decreased septal hypokinesia in the left ventricle, right also a bit global hypokinesia, and an estimated pulmonary artery pressure of 50, and mild mitral insufficiency and tricuspid insufficiency. So an elevated PAP for sure. This lipidemia, kidney deficiency with a creat that is slightly elevated, and intermittent claudication, but the patient is walking several kilometers a day to improve that. forced expiratory volume in the first second is 96%, so the lungs are good, and hemoglobin adjusted DLCO is also 110%, so the lungs are actually very fine for his age. On CT scan, we see an adenocarcinoma in this position, and I'll try to show you the video. It's not going that fast. Let's try again. You really have a PowerPoint problem in here, but you can see some lymph nodes in the mediastinum, which could be enlarged. There again. Also one there. Okay, so conclusion, we have an adenocarcinoma, malignant tumor, and some probably inflammatory lymph nodes. Tumor has an SUV max of 4.1, and we have some lymph nodes in 4R being 2.6, and 10 and 11 right 4, and on the left side again 4.8. So that's why we think it's inflammatory, because it's the same distribution at both sides. So 83 years old, T2A in 0M0 stage, not 1A but 1B in this case. Important cardiac comorbidity, as we have shown you. What treatment would you offer to this patient? Surgery, probably surgery, but we need more data, or radiotherapy? And you can answer this one. We are with more than 160 people online, so you can certainly vote. It's anonymous, so don't be shy. Just say what your idea on this case is, and then we can go on. Okay, we already have some votes. About 57% of this of the audience is saying probably surgery, but I need more data. 22% is saying radiotherapy, and 20% is saying surgery. Okay, so most of you need more data. Then we calculated the FEV1 postoperative after a lower lobe resection, being 71%, and also DLCO being 81%. So this seems to be not really a problem. And then a low technology test, being a continuous incremental protocol and a cycloergometer, up to 15 minutes. The patient achieved 9 minutes of exercise, being 85% of the predicted capacity with an estimated VO2 max. So it's not a full cycle test, but an estimated VO2 max of 15 milliliters per kilogram per minute. EBUS was also done, and I guess the most of you wanted to have this EBUS because of the enlarged lymph nodes that were PET positive, and these are negative and representative in all stations. So this is very important. And then, of course, the question is again, what would be the treatment you offer to the patient, being surgery or radiotherapy? I'll stop sharing from here. I hope Dr. Waller is still there. So that's interesting. We have, let's say, 75% surgery and 25% radiotherapy in this case. Dr. Waller, are you still there? Then we can start off, I think, with with Professor Caglar. Oh no, yes. There he is. There he is. Can you still unmute your microphone? Okay, that should be, oh, yes, that should be okay.
The real problems with technology leaving, trying to get through to you. I can't share the screen, I'm afraid. Can you even hear me?
Yeah, we can hear you. You don't have to share the screen if you want to comment. I can also go back to the slides if you want.
Okay, I can't share my screen. I can't get, it doesn't let me load it up. This case is not so much a problem with respiratory function. It's more with pulmonary artery pressure. I guess this is a cardiac cause, mitral incompetence probably. And so we're trying to preserve lung tissue to prevent an increase in pulmonary vascular resistance. We're trying to prevent putting too much strain on the right ventricle. But even so, I would still perform a segmental resection. It's amenable to, again, an apical segmentectomy. And again, I would use robotic surgery in our institution to preserve lung parenchyma, but also to achieve an oncological complete operation.
So this is a stage 1B. You would also go for a segmentectomy, yes?
Yes, I would.
Okay, interesting.
Partly because of his cardiac function. Mm-hmm. It's a relative risk. I would never do a lobectomy in somebody with potential right heart failure. So to preserve pulmonary vasculature, I would, yes, even though it's a slightly greater than 2 centimeter.
Okay, let's look for another opinion.
Okay, so this tumor is a little bit bigger than the previous one, and this patient has more comorbidities compared with the other one. Instead of a segmentectomy, I would opt for SBRT for this patient. If a lobectomy cannot be done, that would be my first choice. I would go for an SBRT. As I said, if a lobectomy cannot be done, I would not prefer a segmentectomy for this patient.
Because of the stage?
Yeah.
Okay. Let's tell you what the surgeon or the surgical team has done. There was performed a right lower lobectomy with a systematic lymph node dissection, VATS, 3-port, and levosimedan was prepared in case of heart failure. The postoperative period was actually uneventful. The chest tube was removed on day 2. There was a prolonged length of stay until day 5 to cover possible cardiac problems, but he was discharged on day 5 and is still alive with no complications more than 50 days postoperatively. So the surgery was chosen in this case because it offers the best ipsilateral staging. The patient presented with a good respiratory profile, compensating for the, let's say, regular cardiac situation. And although with a lot of comorbidity, the patient seems to be very active. So that was the reason why the treating team was choosing for a lobectomy. I think we can further debate on this, of course. Let's see. Some questions, or do we go first? Maybe we go first to the global comments on this 2 cases and the stage 1A lung cancer and the treatment, because then some of the questions will already be answered, I think. I don't know who's sharing the screen right now.
Not me.
Okay, then it will be Dr. Waller, I think, which is good. Then it's gonna work out. Now it's a black screen, so this is not good. Dr. Waller, are you there? Are you still there? You are still muted. Okay.
I'm still trying to share. Can you hear me? I'm still trying to get through this technology. I'm sorry, it's very, very poor linkage you've got here. Let me try and share the screen again.
Yes, you can, and if not, I will try to pick up the slides for you.
Can you see that screen?
We can see your screen, but we should go to your PowerPoint.
Can you see any slides yet?
No, the slides we cannot see. We can see your screen, but not the slides. So if you go to share screen and then the entire screen, you can choose your what you want to share.
Stephen, I think you will have to show the slides that I sent you. I don't think I have no connection to share the slides, unfortunately.
Okay.
I sent you the slides. Can you share your screen? I'll talk over them.
Okay, I'm going to pick them up for you. Is that okay?
Okay. Can you hear me?
Yes, we can hear you.
Okay.
I'll just if you say me next slide, and then I'll
Okay, so I'll just start with the summary that SABR has a role, but it's a form of local control only for those patients whose prognosis is determined more by their comorbidity rather than their lung cancer. These patients may, in fact, best be served by just expectant treatment for symptom control rather than trying to treat the lesion radically, because I believe that SABR is the equivalent of poor quality surgical control. Obviously, there is incomplete tissue analysis, there's a non-anatomical parenchymal excision, and there's no assessment of the lymph node metastases. Next slide. SABR is intended to focus on a small area, and therefore is effectively a non-anatomical wedge resection. If you assume that all the destruction is inload, is occurred on the lesion, then the control away from it will always be less than 100%. So it's in no way an anatomical ablation. And clearly there is suboptimal collateral ablation of lymph nodes. No one would believe they would irradiate all of the N1 and N2 lymph nodes in SABR. There is an argument for the abscopal effect of subradical ablation, but it may have some biological benefit, but is never a substitute for complete excision of the tumor. Next slide. Really, if you assume that SABR is a wedge, then is a wedge enough? Well, not unless you have a very small probably less than 2 centimeter pure ground glass lesion. Could you justify a wedge over a segmentectomy? Next slide. Because the meta-analysis of a large series of patients, here 7,000 patients, suggested that the survival from an anatomical segmentectomy is superior to a non-anatomical wedge resection. Next slide. And now we know that a segmentectomy is superior to lobectomy in a stage 1 lesion. The recently presented JCOG 0802 trial, which justifies what I've just been saying. There was an improved overall survival at 5 years, the survival curve starting to separate at 4 years. Next slide. Next slide. Radiotherapy is not such a benign treatment. Let's just go to the previous slide.
Yep.
That there are serious complications from SABR surrounding radiation pneumonitis, rib fracture, and it is not without respiratory dysfunction, of course, with as you can see there, the drop in FEV1 of around 7 to 8%. And when the tumor is nearer to the heart, then there is cardiac toxicity. So it is not a benign treatment, and there are side effects from the energy directed at the tumor. Next slide. And in fact, the risk of surgery in these small lesions, in minimally invasive approaches in experienced centers, is no greater than radiotherapy. So there was no significant difference in overall 90-day mortality between surgery and local treatment with radiotherapy. Similarly, there was no significant difference in the grade 3 adverse events between surgery and stereotactic radiotherapy at 90 days. Next slide. So while a full understanding of the short-term risks is important, then the longer-term survival is what we really are offering the patients. Don't forget that they're not always will the radiotherapists get a tissue diagnosis prior to giving radiotherapy, and therefore some of the results of SABR may be biased because they were in fact irradiating benign lesions. Next slide. And of course, there will be understaging of the tumor because there is no systematic lymph node dissection in SABR. And then for those people that suggest putting the patients through EBUS and then SABR, I think this is really losing the plot to put patients through several procedures, trying desperately to avoid surgery, which is of low risk. You can see there that lymph node upstaging can be as much as 15 to 16% following surgery. Next slide. And of course, the local control is inferior by SABR to anatomical clearance. You can see the types of recurrence patterns there, that clearly there is more lymph node chance for lymph node recurrence if you only irradiate part of the lung. And of course, if you only perform a wedge resection, you would expect the local recurrence to be higher than an anatomical segmentectomy or lobectomy. Next slide. And in fact, when radiotherapists report local recurrence, of course, they only look at the lung, whereas when surgeons report local recurrence, we will report local recurrence in the same lobe, another lobe of the ipsilateral lung, or indeed the regional lymph nodes, whereas SABR series just quote recurrence in the radiotherapy field, and therefore there may be a difference and a bias towards underestimating local recurrence in the SABR literature. Next slide. But the most important thing is that the long-term survival is inferior from SABR compared to surgery. At 3 years, the unadjusted mortality was lowest with surgery, resulting in SABR being associated with an overall better survival at 6 months, but an inferior long-term overall survival. You can see there that the difference points towards, if you want to live longer than say 3 years, then you opt for the surgical resection. Next slide. And an attempt was made to perform two randomized trials, the so-called STARS and ROSELLE trials. But of course, the poor recruitment meant that in the end, the radiotherapy world had to pool analysis of the two trials together. There was substandard surgery, often a wedge. Only 1 in 5 were minimally invasive resections, which may explain an increased early mortality for the surgery group in these trials. And as I've said before, the histology was not always obtained in the SABRE group, which gave an unusually high survival, understandably, not surprisingly, if people are having granulomas irradiated. There was very limited study power to detect any differences with short follow-up and few events. You can see the minute numbers: 31 SABRE and 27 surgery, even in this pooled analysis. So clearly, this can be dismissed. A systematic review of 32 studies again emphasizes the point that surgery is associated with a superior overall survival, cancer-specific survival, disease-free survival, and freedom from local regional recurrence. It is true that stereotactic radiotherapy has a lower operative mortality. So in summary, the case for surgery is that SABRE's a wedge. Wedge is inferior to segmentectomy. We're becoming more commonly associated now with doing segmentectomies. In fact, surgery in some of these higher risk patients can be therapeutic because of the lung volume reduction effect. And of course, with understaging, patients may be denied appropriate adjuvant therapy. And in fact, now with the lack of biomarkers from a larger sample, they may be denied treatment with more specific biological therapies. Comparisons at the moment are inaccurate because of the definitions of local control, and because in a lot of the radiotherapy data, an initial tissue diagnosis is lacking. I think that's the last slide. There may be one more slide. So SABRE, which intends to treat only the tumor with a margin of normal surrounding tissue, can never be oncologically equivalent to the removal of the tumor-involved lobe or segment with associated lymph nodes. Okay. And I would dismiss the abscopal effect as less meaningful than the benefits of local resection. So that for me is the case for surgery over SABRE. Thank you.
Okay, this asks for an answer by the radiation oncologist.
Okay, so I am sharing my screen right now. Can you see my slides?
Yes, perfectly.
All right, perfect. Well, first of all, thank you very much for inviting me. So I know that I am the radiation oncologist, which is a minority in this crowd. I try to be very polite. I would like to draw everyone's attention that the patients who are being diagnosed as having lung cancer are old. So this is a fact sheet from 2016, and when you look at the patients diagnosed with lung cancer, 1/3 of the patients are over 75 years old, and 2/3 of the patients are over 65 years old. So we're dealing with an older elderly population. So what is this? What does that mean? They usually have at least one, maybe more, multiple comorbidities. And when you ask those patients, they are not very willing to be operated. And it's variable, especially because of the high risks of morbidity and mortality. And it's a little bit different from the trials because the real world is a little bit different. And especially when the patients are old, they are less likely to receive guideline recommended treatments. And they are less likely to participate or be eligible for clinical trials. And when you look at the community practice, which is a crowded area where treating lung cancer, one-third of the patients even do not have surgery for various reasons. Maybe they deny, maybe they have potential comorbidities whatsoever, but this is the real world. And those patients who are not maybe technically or medically operable, but they not having surgery, were being sent home at the early areas, especially when you look at this Netherlands data from 2001 to 2009. So most of them were having no treatment at all, or they were being treated with conventional radiotherapy, and they had suboptimal outcomes with very low overall survival values, and most of them having roughly around 50% local failures. But with the introduction of SBRT, or so-called SABR, we can focus the beam, and with the help of the technology, we can account for the motion using 4D planning. Use many beam directions for targeting small tumor volumes with steep dose gradients and high dose refraction, and do an accurate targeting to treat those patients elegantly. And this is very convenient because it's outpatient. The treatment usually finishes in a couple of minutes, and the entire course finishes in 1 to 2 weeks. Even in one session, we have evidence for that. There is no need for sedation, anesthesia. It's painless, and usually the patients immediately return to their activities, especially in this area of the COVID pandemic. I think it's a very convenient treatment technique. And the current trends have changed. This is, again, the same Dutch data, but from a more recent area. Now the patients are being treated with radiotherapy compared with the older time period. And it has been proven that SABR is better than conventional radiotherapy, both in toxicity and in oncological outcomes in 2 phase 3 randomized trials. So we have high-level evidence for this. And those are the guidelines. So we have European guidelines, the American guidelines, and those guidelines are endorsed by the International Association of the Lung Cancer. What do those guidelines say? They say that SABR is the guideline recommended treatment for inoperable tumors. And now we are the standard treatment technique for inoperable tumors. Obviously, we are not debating for the operable group right now. And it has to be delivered in 1 to 5 fractions. And as long as the biologically equivalent dose is more than 100 gray, the local controls are good. And I would like to make a little bit comment on a non-diagnosis. We usually, the guidelines recommend, whenever possible, to have a tissue biopsy. We always tend to have a tissue biopsy. We do not like to treat the patient without a biopsy, but we have to remember that those patients are medically inoperable, and sometimes they cannot be biopsied because of high comorbid illnesses. Or the patients refuse to have a biopsy. We only treat those patients without the biopsy as long as the radiological evaluations have a high probability of having a cancer with a PET scan and in a multidisciplinary way. Unfortunately, there is not one globally accepted definition of medical inoperability, so this is a struggle for us, but the standard definition is if the anticipated operative mortality is more than 1.5%, then this patient is medically inoperable. But well, this has to be a multidisciplinary approach, and in the team who defines the medical inoperability, there has to be at least one anesthesiologist, one pulmonologist, thoracic surgeon, maybe cardiologist. So this is a multidisciplinary decision. And those are the patients that we're treating right now, which guidelines recommend. Obviously, there are a lot of factors affecting the tumor control in radiotherapy. I do not want to go into details of this, but the most important thing is the biologically effective dose. As long as the dose is high, those are from old series, but new series are coming again. The most important thing is the dose that we give and the type of the treatment, the treatment plan. So obviously there are, SABRE has been used for operable tumors as well. Those are all retrospective data, and the number of the patients that has been included in those reports are very low, so we cannot draw conclusions for this. I cannot say that SABRE is an alternative approach for surgery in medically operable patients right now. But we have to keep in our minds, there are multiple retrospective analysis studies comparing survivals after surgery versus SBRT. In some of them, surgery is superior to SBRT. In some of them, they're all equal, but we have to keep in our mind that there has to be a statistical adjustment for baseline factors, as long as they're retrospective. What sort of a high statistical design you make, it's all going to be comparing apples and oranges. So this is a propensity score meta-analysis comparing surgery versus radiosurgery. The overall survivals favor surgery because the younger patients were treated with surgery, but disease-specific survivals were more or less the same. Neither lobectomy nor sublobar resections were better in terms of oncological outcomes. But obviously the best way is to randomize. Unfortunately, there were 3 randomized trials that was closed early because of the low accrual, because we couldn't accrue enough patients for those. This is the analysis, the prospective analysis of the 2 preliminary closed phase 3 randomized study. This is we cannot draw any conclusions from this data because the number of the patients analyzed in this study is very low. But in a short period, the outcomes of SABRE was better than surgery in this prospective analysis. But as I said, we cannot draw any conclusions. It could be dedicated to immunogenic effects of the SABRE. We will see in the future. But fortunately, now there are going randomized trials of SABRE and surgery. This UK trial has been closed due to low accrual. They are not randomizing anymore. But the 2 US trials and the Chinese trial is still ongoing, and probably we will have a feedback of it in the near future. So this is the most important thing. The reason why the elderly, the first generation randomized trials were closed preliminary is because of the randomization process. Now with the US trial, the Valor trial, which had included the most number of the patients so far, has the randomization where both the pulmonologist and the surgeon and the radiation oncologist has been involved in the randomization process. So those are the major criticisms by yourselves: treatment without pathology, lack of nodal staging, and I would like to comment on those a little bit, not to increase the time that I thought. So this is the approach of treating without pathology. As I said, we do not like to do this, but in the guidelines, especially in the European and the American guidelines, as long as a multidisciplinary team agrees, and if the patient cannot be biopsied or refuse to be biopsied, as long as we have positive PET scan, the patient can be treated with SBRT without a biopsy. But usually this is less than 20% of the whole patients that we have treated so far. This is the most common criticism coming by the thoracic surgeons, that we do not do lymph node staging or sampling, so we are missing the number of the patients that has to receive adjuvant chemotherapy. So this is a basic math. So if we treat 100 patients with surgery, then according to the Starfolio, and this is more or less the same data, 16% of the patients could be upstaged to N1 or N2. And those are the group of the patients who needs to be preceded with adjuvant chemotherapy. The compliance of the adjuvant chemotherapy trials are usually like 60 to 50%, depending on different trials. And the overall survival is 5%, absolute overall survival increases 5%. So we have to treat 0.5, the number of the patients needed to be treated is 200 if we want to increase overall survival. So it's not a very big issue, especially when the patients are 1A and peripherally located tumors, because the probability of having a positive mediastinal lymph node after a negative PET in this group of patients is very, very low. And surgery obviously has complications. This is an ACOSOC trial published from 2011, included the surgical outcomes of early stage lung cancer. You see, especially for the elderly group, the perioperative complications were roughly around 40%, and there was around 2% mortality. And this is a comparison from the 30 and 90-day mortality from surgery and SABRE as a pool analysis, a multi-center pool analysis. And obviously the surgical mortalities, both 30 and 90-day mortalities, is a little bit higher than SBRT. So as a summary, SABRE is a good treatment option for medically inoperable patients. The definition of medical inoperability has to be made by a multidisciplinary team, and it's essential. And we have to do a shared decision making. That means the patient has to be aware that there is another option apart from surgery before proceeding with surgery. That's the only thing that I would like to mention here. And what's going to happen in the future, obviously, we have to learn it from the prospective trials that are still ongoing. Thank you very much.
Thank you, Dr. Caglar. Very interesting insights from both of you. I'll look to the audience for any comments. I see that Dr. Caglar already answered on some questions. I pick out Dr. Nuria Novoa, who presented or who provided one of the cases to both speakers. Don't you agree that we are probably going towards a less invasive approach for small tumors in operable and inoperable patients? I mean, using SBRT, but when tumors are larger, central, or with lymph nodes problems, these are surgical cases. Any comments, Dr. Waller?
No, I don't agree on where the tumor is. That shouldn't make the decision. I think it's for me, does the patient expect to live for longer than 2 or 3 years? And that can be a decision made with their referring pulmonologist, cardiologist, or any other comorbidity. If the patient expects to live longer than 3 years, then they should have surgery. That's very simple.
Then we can go back to the second
why
case.
you'd want to treat people radically if they have a survival of less than 2 years due to their comorbidity, I'm not sure. I would have thought you're trying to palliate those patients, so why put them through the complications of radical treatment? Why not just palliate their symptoms? It's likely they will die of something else other than their lung cancer. So why treat it radically?
Okay, then we can go back to the second case with a patient of 83 years old. I don't know what his life expectancy would be, what the mean life expectancy in Spain is, but 83 years old, will the patient live longer than 3 years? That's the question. I'm playing devil's advocate.
I can make comments about it.
Yeah.
Well, that was my issue. He was 83 years old with a lot of cardiac comorbidities, and the surgeons claimed that because of the mediastinal lymph node staging or sampling, they have preferred surgery over SABRE. And you know, the only reason to do a mediastinal lymph node sampling or staging is in order to have a prediction of adjuvant chemotherapy. But adjuvant chemotherapy trials have not included patients over 70 years because the compliance is very low and it has a lot of comorbidity, it has a lot of toxicities. So why would do a lymph node staging for the 83-year-old gentleman to take him to the operating room instead of doing a SABRE? I would still opt for SABRE for that patient.
But I think we've moved on now from cytotoxic chemotherapy. TKIs can, of course, be given to patients in their 80s. So I don't know why you would not want to get all the tissue and enable all the biomarkers to give the patient TKIs if possible. And of course, we haven't even scratched the surface of immunotherapy and other targeted biologicals. So I think it's a bit of an old-fashioned approach just to ablate the tumor, what you can see on the X-ray, rather than trying to get all the science and the tissue you can to benefit the patient.
As far as
you're not going to treat metastases better when he develops them, if you know what the original tumor was.
Right. So as far as I know, you can get a detailed pathological evaluation from a biopsy, but we can. So we don't have to have the full sample, including the lymph nodes. And right now, still the most appropriate adjuvant therapy for the ones who need adjuvant therapy is chemotherapy. We do not have enough evidence for adjuvant TKIs and immunotherapy. Obviously, there are ongoing trials.
Well, we will have, obviously. It's not.
Yeah, we will. Right now, we don't. So we're talking about now.
I'm talking about the future. I always look to the future. Surgeons look to the future. So radiotherapists are stuck in the past, of course.
Okay, this is a very hot topic, as you can see. Maybe I should have a look at any questions that are not answered yet. Is there a size limit for the tumor for SBRT, and how about the lymphadenectomy in 1 or in 2 in these patients? Maybe we go for the limitation for the tumor size first.
Right, so the guidelines recommend tumors less than 5 centimeters, but we know that when the size gets bigger, the local control rates go down, just like the surgical series. But for the guideline recommendations, we can treat T1 and T2 tumors less than 5 centimeters.
Okay.
And we do not have, there was a question, we do not have a limitation for the location. In the past, we used to have, there was a no-fly zone, especially when the tumor was centrally located. But now multi-center studies have been published, and as long as you go in the right fractionation schedule, there is no fly zone. There is a fly with caution zone right now.
Okay, and about the lymphadenectomy in 1 and 2 in those cases?
Well, obviously, the flow of the radiotherapy is we do not do a lymphadenectomy. Oh yeah.
There was a question for Dr. Wallace. I'm sorry.
Sorry, what was the question again?
Well, how about lymphadenectomy was the question here. How far do you go in lymphadenectomy, for instance, in these 83 years old patient? Do you do a full?
No, I don't know. Well, that would be the equivalent of doing I don't believe in doing a surgical wedge resection. Put it that way. So, and those patients should have SAVR. If you can only offer the patient a wedge, then they shouldn't have an operation. So, so if I did an anatomical resection, it's just routine. It's part of the operation to do a systematic nodal resection. I wouldn't draw the line at do less than that.
Okay, and would you make a difference?
So I would never do a surgical wedge. Those patients should have radiotherapy.
Okay, and would you make a difference in your mediastinal lymph node dissection if you do an segmentectomy or lobectomy?
Not at all.
Just the same. Okay, thank you. It's already 7:08. I think we have had most of the questions. I also think we can agree with both experts that this all these cases should be discussed in a multidisciplinary meeting to make sure that the patient has the best treatment that can be offered. For me, today, this was a great ESTS webinar again with over 170 live attendees, many interactions, also between the experts. On behalf of the ESTS Learning Affairs Committee, I would like to thank you, Dr. Caglar, Dr. Waller, for the excellent webinar today, and you, the audience, of course, also for your interest and your interaction. This was the last webinar of the current season. I hope to see you all during the ESTS virtual conference, of course, and I hope to see you then afterwards again next season. We will offer you a new series of webinars, including expert lectures and multidisciplinary discussions again from October. So keep an eye on our ESTS website and the social media for further details. I wish that you can enjoy part of the summertime and for you and your family, of course. And I really hope that things will get back to normal after the summer. Thanks again and stay safe.
Thank you very much. Thank you, Dr. Caglar.
Thank you very much. It was a pleasure. Thank you.
Thanks.
Bye-bye.